All right. Thanks, Christina, for that introduction, and thanks everybody for joining tonight. I know that Phillies start in an hour, so don't worry. I'll have you out of here with plenty of time to get ready for the game. Again, I'm Megan Bishop. I'm one of the new sports surgeons at Recon, and going to be going through the lecture tonight. And I appreciate everybody coming in. Looking at knee pain. What are couple of the most common causes of knee pain? Going through treatment options, and then kind of adding in whether or not you can still continue to exercise throughout this type of knee pain. So just a little bit more about myself. I'm a sports medicine surgeon at Reconstructive Orthopedics. I practice in Morristown office, Medford office, as well as Bordentown. I operate generally out of Vantage Surgery Center, which is in Mount Laurel. And we also do inpatient at Virtua. I attended the College of William & Mary, where I was a track and field runner. I ran cross country and track. So always very interested in treating athletes. I did my medical school training at GW in DC, continued to move back up north, and then was at Thomas Jefferson in Philly for my orthopedic surgery residency. And then I spent my sports medicine fellowship in New York City at the Hospital for Special Surgery. It was a great year. I was able to cover the Knicks, so I attended every game at Madison Square Garden for a year, which was a super cool experience. Have covered D1 sports. Before I moved practices from Reconstructive, I was practicing in New York City for quite some time. I was the head team doc of the New York Empire, which is an ultimate Frisbee professional league, and we actually won the championship this year before I left, so that was pretty cool. And then, this bottom picture to the right, I'm covering the elite medical at the New York City Marathon, which I will be training up to do that again this Sunday. Looking to be a hot one, so it's going to be an interesting race for sure. But a little personally about me, I'm a big runner. Love taking care of athletes, love running myself. I ran in the Olympic trials and the marathon back in 2020. So definitely have a personal understanding, of injuries, as well as how to treat athletes and the mentality of an athlete and active person. So today, kind of the goal is to go through knee injuries and some of the most common causes. I'll start off with some background and kind of anatomy of the most common causes of knee pain. And then we'll go through a few of the highlights of the most common topics. So first, knee pain is incredibly common. We treat it a lot. Patients complain frequently of knee pain. It affects about 25% of adults in the US. The prevalence is higher, obviously, as you get a little bit older, with the highest over the age 75 age group. And we see knee pain particularly more commonly in women, and it's often patellofemoral pain that we see more frequently in women. When we look at the knee, we have to think there's a lot of parts to it. So it can be broken down into a number of different parts, which can cause pain. So there's muscles and tendons, there's cartilage that lines the joints, there's the bones, there's nerves, there's blood supply, and there's ligaments that all can contribute to pain. So when we look at the knee anatomy a little more specifically, so when we talk about the bones that make up the knee, we talk about the femur or the thigh bone, the kneecap or the patella, and your tibia or your shin bone. Your fibula is also on the outer portion of the knee as well. And then the knee has a number of ligaments that help control stability of the knee and can often be injured in sports type activities. So your anterior cruciate ligament, which crosses in the middle of the knee, with your posterior cruciate ligament, which help control front to back as well as rotational stability. You have your medial collateral ligament or your lateral collateral ligaments, which help to control some side to side stability. You have the meniscus, the medial meniscus and the lateral meniscus, which are C-shaped cartilage structures that line your joints and help act as shock absorbers. And you usually have the articular cartilage, or the nice smooth lining of the joints. And all of these can contribute to knee pain. So first we're going to talk about is meniscus tears. So first, what is the meniscus? The meniscus is a C-shaped cartilage pad that is found in between the inner and outer portion of the knee, or the medial and lateral compartments. Seen in this picture here, this is the femur and the nice cartilage that lines it. This is the tibia below, and this structure that you can see on the outer portion here is the meniscus that lines it. Meniscus acts as a shock absorber, so it helps absorb force that goes through the knee and dissipate it. It feels very tough and rubbery, and it helps to act and to cushion the joint. So when you injure your meniscus, you lose some of these functions. People that have meniscus tears, what kind of symptoms do they complain of? So oftentimes the acute meniscus tears will occur after an injury, such as like a twisting injury or something like that. patients will feel discomfort on either the inner or the outer portion of the knee right along the joint line. It's usually aggravated by activity. People can get swelling with it. It can cause stiffness, and occasionally it can cause some catching or locking where the patient actually feels a piece of that meniscus getting stuck in their knee. When we examine and try to diagnose a meniscus tear, first we start with clinical exam. So first thing I'm always looking for is to see if the knee is swollen, whether or not there seems to be any fluid on the knee, especially after an acute injury. This is kind of a telltale sign that there's definitely something that happened inside the knee joint. And then specific to meniscus tears, we look for joint line tenderness. So this example of a person using their thumbs to push on the joint line here. And usually there's a point tender spot that will hurt. With arthritis, it's a little more diffuse tenderness. So you can kind of push all over the knee and it hurts. With meniscus tears, it's really more point tender. And then there's a number of specific tests that we can do to test for meniscus tear. This bottom left picture, this is called a McMurray's test, essentially where you're flexing up the knee and somewhat twisting it to be able to see if you can elicit a click or more pain. And that can be suggestive of a meniscus tear. And then we always send patients to get further imaging. So always get x-rays in the office. This will show if there's any kind of arthritis in the knee. We look for any kind of alignment issues, whether the patients are bow-legged or more knock-kneed. And in acute injuries, we'll obviously want to rule out that there's a fracture. But MRIs give us our definitive diagnosis for meniscus tear because the MRIs will show the soft tissue. So this is an example of an MRI in these two pictures here. The first on the left is from the side and the other MRI slice is from the front. So this red arrow is pointing to what we look for when we see meniscus tear. So the meniscus looks like this black kind of triangular shaped structure. And when you see a white line through it, that suggests there could be a tear. So there's a number of different types of meniscus tears, and this kind of depends. These types of tears will dictate how we treat the tear. So again, as I said before, tears can be related to a specific injury or twisting event. A lot of times they happen in conjunction with something like an ACL injury. These tears are often the big, what we call bucket handle tears, where a large piece of the meniscus will flip. And we can also have like specific flap tears. These are the types of tears that we often try to fix, these large pieces of meniscus. There's also more degenerative type tears. These are the tears that come with kind of wear and tear with time. And we see these tears associated with osteoarthritis. So our cartilage becomes weaker and starts to wear and thin with time and aging. And the age-worn tissue is going to be more prone to tearing and degeneration. So this can happen even just with a very minor injury or something that sometimes people don't even really notice or can recall an exact time when the meniscus started tearing. But you can see these examples of this types of meniscus tear. So it's very tattered on the edges. And this is a generally degenerative type process. And there's one other type of meniscus tear that I'll bring up that's gained more attention in recent years. They're called meniscal root tears. And this is where the attachment site of the meniscus is actually torn off. And as I said before, the meniscus is a C-shaped structure. So there's an attachment site in the back of the meniscus and an attachment site in the front. And you tear off completely that attachment site in the back. And when that happens, the meniscus isn't really able to function well. And you can actually get arthritis in a much faster fashion. So I always keep a lookout for these when I look on MRIs. Sometimes they are missed. And, you know, if this does occur in an acute fashion, which can happen with an injury, and the patient has very minimal arthritis, even if you're an older patient, then we consider fixing these with surgery rather than just trimming it, as we do with some of the degenerative tears. And this is an example here of kind of putting the sutures through that attachment site of the meniscus, and we actually drill a little hole through the tibia to attach it into an anchor. So how do we basically treat meniscus tears kind of from the start to finish? So oftentimes we can do non-operative treatment for a meniscus tear. That starts with activity modification, trying to avoid activities that seem to bother it. You can take anti-inflammatory medications or NSAIDs like Advil or Aleve. You can also do physical therapy to help kind of strengthen the knee, get your motion back. And they can also do things to take down the inflammation, like ultrasound ice, stim to get the quad firing. So there's a number of things that you can do through physical therapy to help your pain and help your function. You can also try some injections for the knee. Oftentimes, especially in the degenerative type tears, we'll try a corticosteroid injection. to see if this will take down the pain and allow the symptoms to improve. Oftentimes, the meniscus doesn't have great healing capacity, so oftentimes the meniscus won't heal with this, but it can become asymptomatic to the point that you can do all your activities of daily living and exercise. And if you can get to that point without needing surgery, sometimes that's enough. And I often get the question, if I injure my meniscus, can I still continue to work out? So this depends on the type of tear, the location of the tear, and kind of the setting of how the tear occurred. And it depends on patient symptoms, but many times, yes, you can. So, and those degenerative type meniscus tears that are more wear and tear with time, like I said, a lot of times we'll try to rehab those and get you back to a point where you can do most of your things. And it's totally fine to work out on that as long as you're tolerating it and it's not getting worse. Sometimes athletes will tear their knee or their meniscus. Joel Embiid in the playoffs 2 years ago, might have been last year, tore his lateral meniscus, and he finished the playoffs with this injury and got surgery later. So oftentimes, if you can abate and manage your symptoms, you can continue to exercise and do your activities until it's either a good time to have surgery or, if this become asymptomatic. However, certain meniscus tears do require faster surgery, such as meniscal root tears or some of those bigger flaps like bucket handle tears that can actually limit your range of motion and things like that. But ultimately, it comes down to your symptoms and, the expectations of your performance. And then finally, surgery is one of our mainstays of treatment for meniscus tears. This can either be a repair where we actually fix the meniscus with suture, or it could be where we trim the meniscus, which is called a partial meniscectomy, either on the inner or outer portion of the knee. Again, this depends on the type of the tear, the location of the tear, and the pattern of the tear. So, tears that are a little closer to the periphery or the edge of the meniscus. In this picture, they're shown what's called the red zone versus the white zone. All of the blood supply of the meniscus comes in through that periphery or that red zone. So those are tears we know have a better chance to heal. When the tears are further from that blood supply or the white zone, those tears generally don't have a great chance to heal. So oftentimes we would trim those rather than repair those. So this is a decision that's often made during surgery, which is kind of in this picture down here. That's an example of what arthroscopic surgery would look like for a meniscus tear. And here's a video that just shows kind of some of the instruments that we'll use during arthroscopic surgery. That's a shaver, and that's actually trimming down a loose piece of cartilage. On the left, top left, there's a picture of what we call a biter that we'll use to bite down some of that thick meniscal tissue. And then this bottom left picture shows the evidence of some kind of peripheral or inner rim tearing of that meniscus, and then what it looks like after you trim those edges. And obviously, we always try to save as much meniscus tissue as possible just for the long kind of term health of the knee. And patients will ask, part of my meniscus was gone. Is this going to make me get arthritis? A lot of times, definitely there is a chance if you take a huge piece of meniscus that can increase your chance. But we always do try to save as much meniscus as possible. We will always try to fix the meniscus if it's fixable when you're a younger patient and you're doing it. But in some of those older degenerative tears, those meniscal tears are pretty tattered, and the meniscus isn't really functioning that well anyway. So that tissue isn't doing a great job except for causing you pain. So in those cases, I can't really say that it would have made a difference if that meniscus tissue was still there. So, long story short, we always do try to fix it if we can and preserve as much tissue as we can. But if that's not the case, we'll save as much as we can of the meniscus. So our second topic is runner's knee or patellofemoral pain syndrome. This is incredibly common injury. We see a lot in orthopedic clinics as well as physical therapy clinics. This is a softening of the articular cartilage underneath the kneecap. So it's basically patients that come in and complain of pain in the front of their knee. It can be on the front inside, it can be on the front outside, but it's mostly described as anterior knee pain. What this is caused by is that kneecap is not actually tracking right where it sits in the groove. So that's going to cause inflammation of kind of the structures that line the knee joint, which is called the synovium, and sometimes pain in the underlying bone and structures. Generally, we don't see anything on an MRI that is always structurally wrong with the knee in this type of diagnosis. It's more kind of a combination of factors that lead to this. So again, this is where patients describe anterior knee pain. And you see this picture here, the red kind of areas are some of the most common areas where patients will describe pain. Sometimes patients describe popping or clicking underneath their kneecap, especially with bending type activities. They'll get pain after sitting for prolonged periods of time with the knees bent, and then stiffness when they go to stand up, and then pain, particularly going up and down stairs, but mostly downstairs is where patients will describe the most pain. So this is an overuse type injury in general. So it often happens, when patients are doing more activity or pick up running for the first time. But I've also seen it even in the pandemic when patients were sitting for a longer period of time, at home, working from home for 8 hours a day, not getting up. So it can occur with any type of overuse, even if it's underuse of the knee. We sometimes see it with patients that have kind of alignment issues to their kneecap, whether or not they have a long patellar tendon that will make their kneecap ride high. Sometimes patients have a little more tilt to their kneecap, which can lead to help predispose patients to this as well. But one of the main issues is actually kind of what we call a neuromuscular imbalance in the legs. So certain muscle groups, such as the quad and the glutes and the hips, muscles are generally weak. And this kind of leads to increased contact pressures and forces underneath that kneecap. And then, can cause pain. So ways to improve this, are working on that muscle imbalance. It can also be caused by patellofemoral arthritis or arthritis underneath the kneecap. So we diagnose this mostly through clinical exam. So assessing the kneecap stability, any kind of tenderness to palpation around the kneecap, looking at lower leg alignment for any of those issues I just mentioned. I always have patients kind of assess their quad function to see how well their quad is supporting their knee. And I'll do this through having them do a squat or having them do a one-legged squat. If they're super wobbling, or if you tried at home and you're wobbling a ton trying to do this and you really can't control your knee well, then you're definitely weak in those important muscles that stabilize that kneecap. So that can be improved with physical therapy. When patients fail kind of the initial non-operative treatment, we'll send for an MRI just to make sure there's no kind of cartilage damage or anything going on underneath the kneecap. So the mainstay of treatment for this is going to be physical therapy. So sometimes it can take quite some time. It's not necessarily just the 6 weeks that we generally prescribe. It can take up to months. And I always tell patients that have this, it's can be a lifelong problem. So even after you graduate from PT, you should really keep doing these exercises long term. This is going to be focusing on, like I said, correcting that neuromuscular imbalance and those strength issues in your leg, as well as some of those tightness issues in the leg as well. In terms of, rest, ice, compression, elevation can always be helpful. Anti-inflammatory medication. Some people will try bracing and taping. So you can tape the kneecap in a certain position. That might help it track better. There's certain braces that can do this as well. I'm plus or minus on them. If it does seem like it helps the patient, I say go for it. If it doesn't, I don't think there's really much structural support that it's giving. It's oftentimes a little bit more on the mental side. Injections can help. We can do cortisone shots for this. We can do gel shots or viscosupplementation injections for this. And then, I always have patients I can look at their feet as well, making sure they're not very flat-footed. Sometimes if you have a flat foot, that can contribute to your knee pain, and an orthotic could help. So, if you're diagnosed with runner's knee or patellofemoral pain syndrome, can you still work out? Can you still run? I generally say yes, you can continue to work out through this. You should try to avoid any kind of deep squatting exercises that seem to aggravate it. And my golden rule I usually tell patients is if it really hurts, you probably shouldn't do it. So if you can go out and run 3 miles or run 1 mile and it generally doesn't really get any worse and you still just have a little bit of dull pain after, then that's probably okay. As long as it's not getting worse in signs of pain and symptoms of swelling and more clicking, then you can continue to do activity. If it does seem like it's starting to get better or starting to get worse, then you probably should take a step back from those exercises. Generally find what doesn't hurt and it's okay to do. And, as long as you're continuing to do your PT exercises and see improvements while still doing your general workout regimen, then you're usually okay to continue. Treatment for this, if you fail the non-operative treatment, there are surgical treatments for patellofemoral pain syndrome. Sometimes, like I said, you can have cartilage injury underneath that kneecap. You can go in and you can clean it up if there is mechanical symptoms with that. Generally, that's really limited for specific patients that really do have mechanical symptoms, and that this finding on the MRI, that would be very rare. You can also do something called a tibial tubercle transfer, which is where we essentially realign the kneecap. This is for those large, malalignment tracking issues. You move the tibial tubercle, which is where the patellar tendon inserts, and fix that with 2 screws to kind of bring that anterior as well as medial, and just try to drag that patella from tracking so laterally. We can also do this to offload cartilage injuries underneath the kneecap as well. So oftentimes that's in conjunction. But this is really for those recalcitrant cases that do not get better with a very long time period of therapy. So another quick topic just to touch upon is IT band syndrome, or iliotibial band syndrome. So your iliotibial band is a kind of fascial or thick band that goes all the way from your hip, goes down the outside of the thigh, and attaches on the outside portion of your tibia and crosses right across your knee. So patients can describe with IT band syndrome pain out on the outside of the knee, pain in the middle of the thigh or on the outer portion of the thigh, as well as pain around the hip. But we're talking about knee pain today, and that I would say that's the most common place I see it. Patients that get IT band syndrome often have recent training changes, meaning they've started a new cycle of training for a race, or they're often, I see it when patients taper for a race. So like leading up to the New York City Marathon or the Philadelphia Marathon, those last couple of weeks of training, patients will often start to get some irritation around their IT band. I see it when patients run on uneven terrain or hills. On exam, you're going to be tender on the outer portion of the knee. So this is really a very specific area. Treatment for IT band syndrome is generally, rest if it's not getting better, anti-inflammatories. Again, physical therapy is going to be a mainstay of treatment for this. The IT band you can stretch away. So I always say just whenever you're sitting at your desk at work, just keep stretching. Foam rolling can be very important for this as well. And then for those recalcitrant cases or those patients that, train for a full marathon and this IT band syndrome is really preventing them from, getting to that finish line at that point, we can consider an injection in the IT band, such as a cortisone or a steroid, or something called platelet-rich plasma, which I'll talk about a little bit more later, which is a biologic injection. So, once you get diagnosed with IT band syndrome, can you still continue working out? As I said before, yes, you generally can stretch away as long as it's not getting worse. Sometimes heating it to warm up before you work out can be helpful. Try to avoid hilly terrain and run on more flat surfaces. That can, prevent this from getting aggravated. Make sure your shoes are updated. You shouldn't be running in shoes or working out in shoes that are incredibly old. They don't absorb shock as well, so that can help. And as I said before, you should rest or cross train if you're not improving, but these are all things you can do to try to continue to work out. And so finally, the last topic we'll talk about is arthritis and some isolated cartilage injuries of the knee. So what exactly is arthritis? So arthritis is when you lose the nice, smooth, articular cartilage that lines your joints. And obviously it can happen in the knee, it can happen in the hip, it can happen in really any kind of joint in your body. These are pictures kind of to show example of what arthritis looks like. The central picture, the cartilage is the nice white area, and then underneath you see the exposed bone. So that's when it gets pretty much the most severe arthritis you can get, when you completely have no cartilage left in that area. And this will lead to inflammation of tissues and pain. So it's a really big problem. It's the #1 cause of chronic disability in the U.S. By 2030, the number of adults affected with arthritis in the U.S. is projected to reach 67 million people, or 25% of the population. So an incredibly common problem. And there's a number of different things that can cause arthritis. So #1, it's something that just happens with age. Our cartilage itself starts to lose water content. It starts to lose the chondrocytes, or the cells in the cartilage stop to lose their ability to repair themselves. So, it starts to kind of degenerate with time. This can be genetic. There are a lot of genes that can predispose people to osteoarthritis. And, a lot of people will have family members that had it, that they are able to remember. It can also occur to secondary causes. Obesity is going to increase your risk of osteoarthritis on your lower extremity joints. And this is because of the extra pressure that comes with weight. Every pound a patient is overweight is 4 pounds on the knees, I always tell them. So that's great motivation to be able to try to stay healthy and stay active to help improve your knee pain. And also trauma. So an injury to the knee can predispose you to getting arthritis later. So a patient that tears their ACL when they're 18 years old is going to have a much higher risk of having arthritis in their knee in 20 years than a patient that did not. So symptoms of arthritis include pain. It can be more generalized pain throughout the entire medial lateral compartment or really throughout the whole knee. It gets worse when you use it more. Patients often get stiff with arthritis. It gets worse after you've sat or laid down for a long period of time. There you can get episodes of swelling, as well as a grating or catching sensation with movement. We diagnose arthritis through X-ray, so you don't generally need an MRI to diagnose more severe arthritis. We see, as shown here, we lose the normal joint space, so the space between the bones starts to get less and less, so that sometimes in the most severe cases, it can be bone-on-bone arthritis, which is an example there. So when we treat arthritis, there's kind of a ladder step approach to treatment. So we start with the lowest rung on the ladder, and starting with what can help me live with my pain? What kind of non-operative treatments can we start with? So as I said before, weight management, or trying to maintain a healthy weight is really important. It can reduce your symptoms up to 90% in several studies. Modifying activity. So if someone was, a marathon runner, putting in some cross training instead of running every day, like biking or swimming in addition to the running, can be a lower impact on your knees and be able to help you long term. So I always recommend cycling, which I think is really great. Elliptical, swimming. I know it's harder to get in a pool, but people that have access to that, that's great for your joints. But anything to keep you active is good. And then physical therapy can help improve your motion, can help improve your strength, and help dissipate some of those contact forces as well, the more stronger you are around your knee. So other steps, oral medications. So patients can take NSAIDs, usually like Advil, Aleve, sometimes Tylenol can be helpful. Glucosamine chondroitin sulfate is a supplement that can help joint health that you can just buy at CVS, which can be helpful as well. I generally recommend you do not take any kind of narcotic medication for this, such as oxycodone or tramadol. It doesn't help that great with this type of pain. And also it's obviously can cause other issues of addiction and things like that. So the next step is injections that we can offer for this. So there's a number of different injections you can do for knee pain and arthritis. Cortisone is kind of the one that we perform the most frequently. It's a steroid injection mixed with a little anesthetic. It's very effective in taking down inflammation. The problem with cortisone is you don't want to do it too frequently, not any more than every 3 to 4 months, as it's not great for your tissues. But doing 3 to 4 times a year is generally okay. Also, I do find that with cortisone, the more you get them, the less effective they are with time. Generally, people will graduate out of getting cortisone injections frequently. The other type of injection we do for arthritis is called a viscosupplementation or hyaluronic acid injections. And this is there's a number of them listed here. There's a lot of different brands. Essentially, this is like adding jelly back into the knee or cushioning back into the knee. It really isn't adding cushioning to the knee. Really what it is shown to do is help treat pain. You can do that once every 6 months, and that's an option for knee pain as well. And then the next step to talk about is the biologic injections. So these are the kind of stem cells or regenerative type injections that people talk about. The most common one that we do more regularly in the office is called platelet-rich plasma, or PRP. And we do this in a lot of athletic injuries as well. You can do this in tendon injuries such as lateral condylitis and things like that, or tennis elbow. So this is where we take your own blood and then we spin it down in a centrifuge, separating out all the platelets, and then inject that back into the joint. It's actually been shown to work pretty well for knee arthritis. And it does not help regrow cartilage or anything like that, but it can help treat pain. And the same with stem cells. There's never been any kind of studies that show stem cell will regrow cells or heal your arthritis or things like that. The only thing stem cells have ever been proven to do is that in some studies they've helped pain temporarily. But the downside some with that is they're both very expensive treatments. Platelet-rich plasma is much more affordable. It's usually like $750 to $1,000 an injection where you're going. The stem cells can be up to about $5,000 an injection. Like I said, neither of them have shown to regrow cartilage or heal anything. They've been shown to help treat pain. They are an option out there. but just make sure you know kind of what you're getting for these treatments. So once you're diagnosed with arthritis, can you still be active? Can you still work out? So yes, like I said, lower impact activities are better. Incorporating cross training, like I said, more of those non-weight bearing type activities like cycling and elliptical. This is going to help you maintain a healthy weight. And that's going to be the long-term best thing you can do for your knee. And additionally, I always say motion is lotion. So studies have actually shown that some, impacts activity like running on a healthy knee can actually be good for your cartilage. So healthy cartilage can actually adapt to loads by increasing thickness. So getting out there and exercising is actually good for your cartilage. So when we approach kind of the top of the ladder, once we've exhausted all other treatments, that's surgery. So before joint replacement surgery, there's something called joint preservation surgery or cartilage restoration surgery. This is for more isolated cartilage lesions. And when I say isolated cartilage injuries, it's just usually a small area on a certain part of the knee that has damage to the cartilage that's causing pain. This is more for kind of younger patients, like I said, that have that one specific area of cartilage that could be causing an issue. There's a number of surgeries that we can do to treat that. And the mainstays of these are osteochondral allograft or autograft, which is essentially where we take a bone plug with some cartilage on it, either from another portion of your own knee for a smaller defect or from a cadaver for bigger defects, and essentially carve out that cartilage defects and replace it using that donor piece of bone and cartilage. And you can see this is kind of where the defect is carved out, and then you put a plug of cartilage in to replace that. This can be really successful for those isolated cartilage defects. It's a big recovery. It can be, 6 months to 9 month recovery after this type of procedure. But for the appropriate patient, this can be very, very successful. Another cartilage restoration procedure we have is called MACI, or matrix-induced autologous chondrocyte implantation. MACI is a much easier way to say. So this is essentially for those isolated defects as well. But it's a two-stage surgery. So you go in and you scope your knee first and take a small sample of your own cartilage. And then it's sent to a lab where you regrow it kind of on this matrix sheet. And then you can kind of replace that area of cartilage just using that, matrix with your own cartilage cells on it. So that can be another successful procedure as well with the appropriate indications. Other joint preservation type procedures, there's things called osteotomies, and that's for isolated compartmental arthritis. So if you only have arthritis in, say, the inner portion of your knee, and you don't have any arthritis in the outer portion of your knee or underneath your kneecap, and you're a younger patient, under the age of probably 45 or 50, you could be a candidate for this. You actually have to essentially break the bone and realign it using essentially a bone graft in there to realign the forces of the knee, and you fix that with a plate and screws. The idea is to kind of prolong the lifespan of the joint. And again, this is a specific procedure that, you have to have the correct indications for, but it can be very useful for prolonging the lifespan of joints. And so finally, the top of the ladder is knee replacement for that kind of diffuse arthritis that's failed all non-surgical management. You can do a complete knee replacement, which is seen on the bottom right. And there's also partial knee replacements as well that can be done for patients that have arthritis really just in one compartment. So in the end, just in summary, what do you recommend? Staying active is good for you. So, trying to get out there and exercise, even with a little bit of pain, as long as it's not getting worse. And as long as you're doing your therapy type exercises and trying to head on the path to getting better, it's generally going to be good for you. It's important to know your diagnosis, know what is causing your knee pain. There's a number of, causes of things that can cause knee pain. As I described, all the different parts of the knee. We didn't cover a lot of them, but these were some of the main ones. So it's important to know what the cause of the knee pain is. Follow the golden rule that I said, if it really hurts, you probably shouldn't do it. Otherwise, try to stay active. Just watch for signs of worsening symptoms like swelling and increasing pain. Know your options. So that goes into knowing what your diagnosis is. Know both non-surgical and surgical options for your pain. And know yourself. So I always tell patients to make sure they listen to their body, listen to their own needs. And you know your body or your knee better than anyone else. And that's it. So I'm happy to take any questions that anyone has. And we've got about 25 minutes till the Phillies game, so plenty of time.
Thank you, Dr. Bishop. That was great. Like Dr. Bishop mentioned, if anybody has any questions, nothing was typed in the chat box. So if you wanted to go ahead and unmute yourself, you can go ahead and do that.
I have a question.
Sure.
Hi, my name is Debbie. I'm 57, and 4 years ago, I did have a root tear of the meniscus surgery performed. And overall, it's been successful. My number one goal was to get back to running. I was more of a casual runner, but I was in probably the best shape of my life 4 years ago, until I injured it. And it was kind of a sudden thing that came on when I did have to have that surgery. What I guess my question to you is now is here I am 4 years later, post surgery. I'm still able to run a little bit, but I'm having pain. And unfortunately, I'm probably a good 20 to maybe 25 pounds overweight from where I was previously. I'm also 4 years older, so I'm now 57. But I'm feeling pain, and where I do notice it a lot is going down the stairs. I pretty much have to go down one at a time, each 2 feet on one single step. I have good days and bad days at the gym where I some days might not even be able to go to the gym, or I really have to be careful. And I do tend to notice it more, I think, on that lateral movement. So I guess my question to you is, what might you advise me? And is this just an unfortunate natural progression of where I'm at and my age and maybe my weight? Or is there some steps I can take to maybe try to alter that right now?
Yeah, Debbie, great question. So, it sounds like you've had a pretty good course. You're able to get back to running after the root repair, which is definitely the goal, to be able to keep you active after it. If I were you, if you haven't had a new x-ray in a while, I would say it's probably due to get another x-ray, just to make sure it doesn't look like you've gotten any worsening arthritis on that side. Because if it does look like your knee looks pretty good still, it might be worth investigating whether there was a new injury or kind of another cause of the pain. It's definitely possible that you still could have some arthritis that it's developed in that time, even after repairing the root, just based on how it's healed or just based on the kind of the natural process of what was going to happen with your knee. So I think, starting with just getting a new x-ray, if you haven't had one in a while, would definitely be worthwhile.
Okay.
And then kind of take it from there. Certainly an injection or something like that might be helpful too, if you have a little more arthritis on that side.
Okay. All right. Thank you.
You're welcome. Thanks for your question.
Thank you, Debbie. Was there anybody else?
Yes, hi. My name is Mike Simon, a physical therapist in Bordentown. Going back to the topic of the patellofemoral pain syndrome, I've seen a lot of patients, particularly adolescent females, who often come into the clinic with that. And one of the areas that I often look at, in addition to weakness in their VMO, is sometimes they have tightness in their lateral retinaculum, along with IT band. Is that something that you've encountered quite a fair share as well?
Absolutely. Yeah, that's a lot of times one of the main issues as well. So like I said, and I probably didn't explain this as well, but I look at it like a neuromuscular imbalance of, muscle weakness, but also a lot of tightness. So that IT band plays a huge role. The lateral retinaculum plays a huge role. So really working on focusing some of that stretching too, I think is incredibly important. So that's a great point.
Yeah, I just one other additional point. I had an opportunity to take a very good patellofemoral course years ago, and because I had really poor success rate with McConnell taping, and one of the things that I pulled from that course that I still use to this day is a standing patella medial glide stretch. So done in weight bearing, and that usually is quite effective at stretching out those tight lateral structures, correcting any glide or tilt deficiencies, and reducing pain dramatically in 1 to 2 sessions.
That's great.
Thank you for your presentation.
Thank you.
Thank you, Mike. Was there anybody else? All right. Well, if there are no more questions, thank you again, everybody, for joining us tonight. Dr. Bishop, I wanted to thank you again for your presentation. It was very informative. This session was recorded, so it will be available on our website by the end of the week, early next week. If you have any questions, you can give our office a call. 609-267-9400. And we'd be more than happy to help you. Thank you, everybody.
Thanks, everyone. Have a great night. Thanks, Christina.